ရောက်လာကြတဲ့ဆရာဆရာမများအားလုံးပဲမင်္ဂလာပါရှင်ဒီကနေ့ကြီးမားတဲ့ webinar ကတော့မြန်မာ GP Education နဲ့ UK က RCGP တို့ပူးပေါင်းပြုလုပ်တဲ့ webinar လေးပဲဖြစ်ပါတယ်တက်ရောက်နေကြတဲ့ဆရာဆရာမများအားလုံးသိတဲ့အတိုင်းပဲလစဉ်တတိယတနင်္ဂနွေအပတ်မှာ USA က FGMMP နဲ့ပူးပေါင်းပြုလုပ်တဲ့ webinar ပထမသို့မဟုတ်နောက်ဆုံးတနင်္ဂနွေအပတ်မှာတော့ UK က RCGP နဲ့ပူးပေါင်းပြုလုပ်တဲ့ webinar လေးတွေရှိပါတယ်။ကျင်းပပြီးခဲ့တဲ့ webinar များအားလုံးကို recording ပြုလုပ်ထားပြီးတော့ webinar များကျင်းပပြုလုပ်ပြီးတဲ့ရက်မှာ2ရက်ခန့်အကြာမှာတော့မြန်မာ GP Education page မှာ recording video များကို upload လုပ်ပေးထားမှာဖြစ်ပါတယ်ရှင်။မတက်လိုက်ရတဲ့ဆရာဆရာမများအားလုံးလည်းပြန်လည်နားဆင်နိုင်ပါတယ်ရှင်။ဒီနေ့ကျင်းပတဲ့
တော့ရတယ်ဘယ်လိုမှမကြနိုင်ဘူးဒီနေ့ချိန်ပြီးအတန်း
ဒီနေ့ကျင်းပတဲ့ webinar topic ကတော့ primary care management of atrial fibrillation ဖြစ်ပါတယ်ရှင်ပြောကြားပေးတဲ့ speaker ကတော့ဒေါက်တာ Subir Ghosh ဖြစ်ပါတယ်ဆရာက FRCOG ရပြီးတော့မှ GP ကိုစိတ်ဝင်စားတာဖြစ်တဲ့အတွက်ကြောင့်FRCGP ထည့်ယူထားတာဖြစ်ပါတယ်ရှင်လက်ရှိမှာတော့ mouth chamber surgery မှာ GP ရဲ့ထိုင်နေတဲ့ GP trainer တဦးလည်းဖြစ်ပါတယ်NHS မှာလည်း GP appraiser လုပ်နေတဲ့ဆရာတယောက်ဖြစ်ပါတယ်ရှင်professional support and well-being health education East of England မှာလည်း clinical case manager တဦးဖြစ်ပါတယ်ရှင် RCGP international trainer တဦးလည်းဖြစ်ပါတယ်ရှင် May I invite Dr. Subir to give the presentation of primary care management of atrial fibrillation please Doctor the floor is yours
Thank you very much, Dr. Hetek, for the nice introduction. Thank you very much. Mangalarbar. So some of you know me because I'm involved in RCGP international training for Myanmar GPs. Those of you who don't know, I'm Subir Ghosh, as Dr. Hetek said. I'm a GP and I work in Essex in UK, in a big training practice. And I'm also involved in RCGP quality improvement project for Myanmar GPs. Thank you all for attending this webinar. And I'm going to talk in next 1 hour, primary care management of atrial fibrillation. We all know that atrial fibrillation is a common arrhythmia, common disorder of heart rhythm. Obviously, previously atrial fibrillation patients used to be managed by cardiologists, but now with improvement of general practice and with improved facilities available to general practice, more and more cases we are managing in primary care. So I'll be talking mainly from primary care perspective, how to manage a new onset atrial fibrillation patient in primary care or how to follow up cases of atrial fibrillation. So, sorry, just 1 sec. My slides are not moving. Screen share. Can you see it?
Yes, sir. Yes, sir.
Yeah,
we
you can see. Please move.
But it's not moving, so let me do it this way. Just a minute.
Are you using your laptop?
Yes, I'm using laptop,
Yeah.
but
And then-
slideshow is not working. Let me see
Yeah.
if I can do without slideshow. Just 1 sec. Let me try again. Share screen.
You can move with your arrow.
Yeah, but for some reason on this laptop, quite often I find it difficult. So, yeah.
It's okay.
Probably the screen will be a bit small. Sorry about that. So,
Yeah,
as I said,
okay.
atrial fibrillation is a common arrhythmia, common disorder of heart. 5 to 10% of patients over the age of 65 suffer from atrial fibrillation. Quite often it goes undiagnosed. And paroxysmal atrial fibrillation, that means atrial fibrillation which happens and then reverts back to normal, that is paroxysmal atrial fibrillation, that is common in younger patients. Now, going back to our medical school teaching, so we know that heart rhythm starts from sinoatrial node or SA node, which is in the left atrium, right atrium. From there, it goes to the atrioventricular node. The rhythm then goes via the bundle of His to Purkinje fibers and excites the ventricular muscle. So this is the normal heart rhythm, starts from sinoatrial node from right atrium and then goes in a orderly manner to the ventricles. In atrial fibrillation, the atrium contracts from different sources. So it's not coming only from SA node, it comes from other areas of cardiac muscle, and then it contracts or it generates impulse at a rate of 300 to 600 per minute. But all of them don't go to ventricle. Part of them goes to the ventricle and causes ventricular contraction. So this is the abnormality in atrial fibrillation, where the impulse is coming from different foci, different focus in atrium. So in atrial fibrillation, there is continuous and rapid activation of atria by multiple re-entry wavelets. The atrium gets activated up to 300 to 600 per minute, and the ventricle only responds to a proportion of those impulses. Now, what are the causes for this abnormal impulse generation? So it could be due to anything which caused raised intra-atrial pressure, so which could be due to backflow, due to mitral regurgitation, could be due to aortic regurgitation. So anything which increases atrial pressure, or anything which increases atrial muscle mass, like hypertrophic cardiomyopathy or viral cardiomyopathy, or if there is any hypertension which causing heart enlargement. If there is atrial fibrosis, so fibrous tissue will produce abnormal impulses, or if there is any infiltration or inflammation, like in case of your any disorders like your pericarditis or myocarditis, when there is inflammation, that can cause abnormal impulse generation. Systemic causes hyperthyroidism and drugs. And sometimes we can't find any cause for atrial fibrillation. Those are called lone atrial fibrillation. So drugs, out of the drugs, common drugs which can cause atrial fibrillation is thyroid medicine. So if we give thyroxine to a patient and if we give higher dose by mistake, that can precipitate atrial fibrillation. That is the reason in hypothyroid patient, particularly in elderly who are above the age of 70, we are cautious about the dose. So we give small dose and gradually increase the dose. The other drugs which can cause atrial fibrillation is some of the medicines which are used for prostate cancer, like enzalutamide, arabiterone. Those medicines can cause atrial fibrillation. So causes, we can think about cardiac and extracardiac. Cardiac, we have already mentioned, mitral valve disease, rheumatic heart disease, which is common in Myanmar, India, Bangladesh. Rheumatic heart disease is still common. It is due to streptococcal infection, which affects the heart, and that causes valvular disease and ischemia of the heart muscles, and that can lead to atrial fibrillation. Following cardiac surgery, pericardiectomy, or valvotomy operation, patient can develop atrial fibrillation. Pericarditis, cardiomyopathy, hypertension is a common cause for atrial fibrillation. That's why we see atrial fibrillation more and more in elderly patients, because they have got long-standing hypertension that leads to atrial fibrillation. Extracardiac, I mentioned about hyperthyroidism. Acute and chronic alcohol abuse can cause atrial fibrillation. Electrolyte imbalance, particularly potassium imbalance. Acute infection, respiratory tract infection, chest infection. We quite often see patients who develop acute lower respiratory tract infection. They go into paroxysmal atrial fibrillation, and after treatment of chest infection, the atrial fibrillation reverts back to normal rhythm. Electrolyte imbalance, I said, and tachybrady syndrome, so that's because of the conduction disorder, and diabetes mellitus. It can cause atrial fibrillation as well. So types of atrial fibrillation, one is persistent, if it persists for more than 12 months. If it comes and goes within 48 hours, if it goes back to normal, then we call it paroxysmal. Permanent, which is permanent, and lone, when there is no cause found. So diagnosis and investigation, how to diagnose atrial fibrillation. This is important for us as a primary care physician, how to diagnose atrial fibrillation. The most important or most effective way of diagnosing atrial fibrillation is checking pulse. So if we check pulse, and if the pulse is irregular, it shows the irregularity is due to atrial fibrillation, and the sensitivity of pulse checking is 91 to 100%. That means if we find irregular pulse in an atrial fibrillation patient, that is sensitive to 90 to 100%. But the specificity is 70 to 77%, which means in atrial fibrillation patient, pulse rate may be regular and normal in about 30% of the patients. So if it is negative, if the pulse is regular, 70 to 77% chance that the patient doesn't have atrial fibrillation, but 20 to 23 to 30% chance is that the patient may still have atrial fibrillation. But if the pulse is irregular and if the patient has atrial fibrillation, the sensitivity is 91 to 100%. Is that clear? So pulse checking is useful to rule out atrial fibrillation. It is good for opportunistic detection of atrial fibrillation. Opportunistic detection means patient has come with something else, but I've checked, or we have checked pulse and we have found out atrial fibrillation, and we are preventing the, by finding out atrial fibrillation, we are starting treatment and preventing the complications of atrial fibrillation. In UK, what we do, any patient who comes for hypertension monitoring, we check their pulse. Any patient who comes for chronic disease management, we check their pulse. Any patient who comes for flu vaccine, we try to check their pulse. It's not always possible because of the time factor, but if possible, we check the pulse. So that way we opportunistically check the pulse. Anyone who has got hyperthyroidism or hypothyroidism, we check their pulse when they come for medication review. So opportunistically we check the pulse, and quite often we find out arrhythmia. Then we do further investigation, and if it is proven to be atrial fibrillation, we start treatment. So 3% of patients over 65 has undetected atrial fibrillation, and given the test sensitivity and specificity, pulse palpation in this group can detect 30% of screened patients. So if we screen pulse for 100 patients, 30 of them may have atrial fibrillation. So it is a very good test. And among the screened patients, 0.2% would have atrial fibrillation, which will not be detected by pulse checking. So pulse checking is very important in the diagnosis, in the initial diagnosis of atrial fibrillation. And when we find the pulse is irregular, then we ask for 12-lead ECG, if necessary 24-hour ECG, if necessary 7-day Holter monitoring, and other tests are, as you know, echocardiogram, chest X-ray, and blood test, mainly to check the electrolytes and thyroid function, renal function, liver function, coagulation screen. So those are the tests we do if we suspect atrial fibrillation. Now, what are the complications of atrial fibrillation? Why to try to diagnose atrial fibrillation early and start treatment? To prevent complications. So what are the complications? If the heart beats irregularly, then what will happen? The blood in the atrium will produce clot, and that clot can go anywhere, can cause deep vein thrombosis in the leg, can cause stroke in the brain, or it can cause any small artery occlusion. So that is one complication. Second is because the heart is not pumping in a synchronized way, it is pumping irregularly. So the ejection will be less, ejection from the heart will be less. So there will be backflow and there will be retention of blood in the heart, and that will lead to heart failure, and it can cause sudden death. So to prevent thromboembolism, heart failure, and sudden death, we try to diagnose it early and give treatment. So prognosis, atrial fibrillation increases risk of having stroke by 4 times. Female sex in patients with atrial fibrillation without rheumatic heart disease is associated with higher risk of stroke. It may be due to estrogen, because women have got high estrogen, which causes a tendency to thromboembolism. On top of that, atrial fibrillation, if they have got atrial fibrillation, that increases the risk of having stroke. Underlying heart disease increases the risk of stroke, which is obvious. 20% patients with atrial fibrillation and a stroke will have a second stroke within 1 year. And 1/3 of patients with paroxysmal atrial fibrillation develop chronic atrial fibrillation over 2 to 3 years. So sometimes we used to say that if someone has got paroxysmal atrial fibrillation and if it gets back to normal, there's nothing to worry about. But that is not true, because 1/3 of them, so 30% of them, will develop persistent atrial fibrillation. And in a follow-up of Framingham study, atrial fibrillation was associated with 50% increase, 50 to 90% increased risk of death. And atrial fibrillation is associated with 2-fold excess all-cause mortality. So it is important to early diagnose and treat and prevent complications. Now, I'm going to discuss about this patient whom I saw recently in my clinic, just to tell you how she presented and what we did. So this is an 81-year-old lady, independently mobile, came on 3rd of April for medication review because she takes Parkinson's medicine, Cyanomet. She is all and clonazepam to help in muscle relaxation, and also she is on antidepressant fluoxetine. So we check any patient who are on long-term medication, we review them every 6 months. So she came for routine medication review, and she did not have any shortness of breath, no palpitation, no chest pain. She came upstairs with her daughter-in-law, and she used the stairs. And when I examined, obviously, because she is on anti-Parkinson's medicine, so we usually check the blood pressure, pulse, and the standing blood pressure to see if there is any postural drop. When I palpated her pulse was 100 per minute, and it was irregular. So I arranged an ECG, which we have in our practice, and ECG showed atrial fibrillation. So what to do? 81-year-old, Parkinson's disease, came for medication review, and on examination, she has been found to have atrial fibrillation. So atrial fibrillation, so what to do? What treatment to start? So first I advised her, I was planning to send her to hospital because it's a new onset atrial fibrillation, although she was hemodynamically stable and her pulse was not very fast. So I said that, okay, hospitalization, but she didn't want to go to hospital. So I started her on bisoprolol 1.25 milligram, started on a small dose, beta blocker. I advised some blood test, full blood count, urea creatinine to check renal function, liver function, coagulation screen, thyroid, and also I did a N-terminal pro-BNP, which is a test for heart function, and it goes high in heart failure. N-terminal pro-beta natriuretic peptide. This is a blood test which goes high in heart failure. Then I saw her in a week time on the 11th of April. At this time, I had all the bloods, which were all normal. And I did a CHADS-FRCOG score, which was 3. I'll come to that in a minute. And her orbit score was 1. And pulse rate remained more or less same, 100 per minute. I also arranged for an echocardiogram. I increased her bisoprolol to 2.5 from 1.5 to 2.5 and started her on Apix-7, 5 milligram twice a day. So this was all done in primary care without referring to cardiologist. Then I saw her again in about 4 weeks' time. By that time, the pulse rate has come down to 86 and her bisoprolol dose was increased to 3.75. I saw her again, her pro and terminal BNP was normal, so it was not showing sign of heart failure. And her ejection fraction was 50 to 54% on echocardiogram. She had mild aortic, mitral, and tricuspid regurgitation, and I referred her to the cardiologist, to the outpatient clinic, not as an emergency, but to outpatient clinic. So, management of atrial fibrillation in primary care. So, urgent hospitalization if there is hemodynamic instability, if the pulse rate is very high, above 150 per minute, or if the patient has chest pain, breathlessness, or syncope, fainting, or dizziness. So they will need immediate hospitalization and stabilization. So management of atrial fibrillation, if they are hemodynamically stable, we can manage in primary care if appropriate, or refer to the hospital for cardioversion. Now, we all know that cardioversion means to try to change the rhythm from irregular atrial fibrillation to normal heart rhythm. So cardioversion is a good option, or is a good treatment for atrial fibrillation because it changes the heart rhythm to normal heart rhythm. And if it persists in the normal heart rhythm, it prevents all the complications like thromboembolism and heart failure. We also need to hospitalize the patient if there is stroke, TIA, or thyrotoxicosis, or pulmonary embolism. If they are hemodynamically stable, there is no stroke, TIA, thyrotoxicosis, then we can refer to the cardiologist, not as an emergency, but as a routine referral for consideration of cardioversion, either electrical or pharmacological. Now, whom to do cardioversion depends on lots of factors, like first of all, age of the patient, activity of the patient, number 3, patient's preference, so, and whether there is any underlying problem like early onset heart failure. So depending on those factors, a decision is usually made whether to do cardioversion or not. Now, so there are 3 principal goals of treatment in atrial fibrillation. One is control of symptoms, because they are getting palpitations, syncope, dizziness. So we need to control the symptoms. We need to prevent thromboembolism, and we need to prevent cardiomyopathy, enlargement of the heart, which is caused by the tachycardia. So if we can reduce the rate, then the heart enlargement will be prevented. And cardiomyopathy will lead to heart failure. So to prevent cardiomyopathy and heart failure, we need to reduce the heart rate. Now, rhythm control, rate control, I've already mentioned. The other goal of therapy is anticoagulation, because these patients, because the heart is beating irregularly, so there is increased risk of clot formation in the atrium that can dislodge, go to the brain, cause stroke. So for that, we have seen that it increases 4 times risk of stroke. So we need to give something to thin the blood. So the effective way of thinning the blood is to give anticoagulation, not antiplatelet, but anticoagulant. Treatment of underlying condition, if any, like hyperthyroidism or heart failure, or if they have got any other cardiac problem, that need to be treated. Early intervention reduces risk of heart failure. Now, whether to do rhythm control or rate control. So rhythm control is more physiologic. So the contraction of the atrium will be more effective. That is one. It improves exercise tolerance. and it prevents the heart failure. So that way rhythm control is better. So there are lots of clinical trials to see whether the rhythm control is better or rate control is better. So AFFIRM trial, which is atrial fibrillation follow-up investigation of rhythm trial, it showed that there is no difference in mortality with rhythm or rate control. There's another trial which is called a RAFT2 trial. So radio frequency ablation versus antiarrhythmic drug as first-line treatment for paroxysmal atrial fibrillation. Here it shows that if the patient did not have any previous treatment with antiarrhythmic drugs, radiofrequency ablation causes less recurrence of tachyarrhythmia. So that way it is superior to drug treatment. So radiofrequency may be better for prevention of recurrence of tachyarrhythmia. So when to offer rhythm control, it all depends on whether it's a reversible cause. So if the patient has got heart failure, they can be better managed by rhythm control. New onset atrial fibrillation may be better managed by rhythm control. Or in atrial flutter, rhythm control is better mainly by ablation. Sorry. Yeah, so how we can do the rhythm control? So rhythm control can be done by drugs or it can be done by electrical means. So it can be done by cardioversion or it can be done by using drugs like, like amiodarone or flecainide. So these two are the anti-arrhythmic drugs which can be used for rhythm control. Electrical cardioversion can be done in electrophysiology suite. So they can put the electric shock and that can revert the rhythm to normal rhythm. Pharmacological, it can be done within 48 hours, ideally, but it can be done afterwards as well. But for cardioversion, the patient need to attend the electrophysiology unit within 48 hours. If they come after 48 hours, then you need to wait for 3 weeks to start anticoagulation first and then do the cardioversion. So if the patient presents early, they can get primary cardioversion. If they present late, they have to wait for anticoagulation to start and then have cardioversion. So pharmacological cardioversion, as I mentioned, flecainide or amiodarone. Electrical cardioversion, the other thing which you can use is catheter ablation, radio frequency ablation. You can do pacemaker, so you can put the pacemaker and that will control the rhythm, or you can put implantable cardiac defibrillator or ICD. Rate control, there are drugs which controls the AV nodal rate. The main group of drugs, there are 3 groups of drugs. One is beta blocker. We use mainly bisoprolol, but you can use nebivolol and bisoprolol, nebivolol, or carvedilol. These 3 are cardioselective beta blocker, which can be used to reduce the rate. Second group of drug is rate-limiting calcium channel blocker, like diltiazem and verapamil. And third group of drug is digoxin, which is not much used nowadays. So after either controlling rhythm or controlling both rhythm and rate or controlling just the rate, next question is anticoagulation, because we have seen that there is 4 times increased risk of stroke, there is increased risk of thromboembolism, so we need to keep the blood thin. So how we can do anticoagulation? Either by giving medicines, which is either warfarin or directly acting oral anticoagulant, or we can use heparin. So these are the 3 groups of drugs we can use for anticoagulation. So who needs anticoagulation? So anyone with atrial fibrillation is at increased risk of thromboembolism. So anyone with atrial fibrillation should have consideration for anticoagulation. Okay. So we use these two scores. I'm sure you also use it in Myanmar. One is called CHATS score, and the second one is called CHATS VASC score. So we put the, numbers like if they have got congestive heart failure, or if the left ventricular ejection fraction is below 40%, they get 1 score. If they are hypertensive patient, 1 score. Age above 75 is 2. Diabetes 1. Stroke, previous stroke TIA, then it gets 2. Vascular disease gets 1. Age 65 to 74, 1, and female 1. So by doing this scoring, we come to a total, and depending on the number, if the scoring is 2 or higher, then we should consider anticoagulation. So we don't give anticoagulation to everyone. So if someone is aged 50, doesn't have high blood pressure, doesn't have any other medical problem, that person will not need anticoagulation. But if at the age of 50, that person has diabetes, that person has got a past history of TIA, then that person will need anticoagulation. So we do it according to the CHATS VASC scoring. Now, after CHATS VASC scoring, we need to think about, because this anticoagulants increases the risk of bleeding, so we need to consider their risk of bleeding as well. So for that, we do another scoring, which is called Hasbled score. So it's same. There are criteria: high blood pressure, abnormal renal function, abnormal liver function, age, past history of bleeding, labile INR. So on that basis, we do a scoring. And if the scoring is more than 3, then we become a bit cautious, because there is increased risk of bleeding. So if the score is 3 or more, there is increased risk of bleeding. Doesn't mean that we should not anticoagulate, but we need to be careful. So risk benefit need to be discussed with the patient as well. Now this Hasbled score has been replaced now by Orbit score, which is outcome registry better informed treatment of atrial fibrillation. So with the Orbit score, same thing, we put the age, bleeding history, GFR, that means renal function, and treatment with antiplatelet drugs. So this, when we put, it gives a score, and it also gives us, according to the score, what is the risk of bleeding if this person goes on anticoagulation. And that we explain to the patient before giving anticoagulation. Now, there are, as I said, there are 3 groups of anticoagulant. One is vitamin K antagonist, which is warfarin, phenydione, and acinocumaril. Directly acting oral anticoagulant, dabigatran, edoxaban, rivaroxaban, apixaban, and heparin or low molecular weight heparin. Warfarin is widely used. Before the invention of these DOACs, we always used to use warfarin. Advantage is it is cheap, it is effective, it is easily reversible, and it has got a half-life of 48 to 72 hours. So if the patient, particularly elderly patient, if they forget to take 1 dose, it will still be effective because it is in the system for 48 to 72 hours. But the disadvantage is it needs regular INR check, international normalized ratio check, and it increases the risk of bleeding. And lots of things can affect the level of warfarin. Lots of drugs and dietary change can affect the level of warfarin and increases the risk of bleeding. So if the INR goes high with warfarin, we have got a protocol. Depending on what is the INR level, we either stop warfarin or reduce warfarin, or we give oral vitamin K. If the INR is very high and if there is any bleeding, then those patients need IM vitamin K injection. Now we have got DOAC for last 15 years or so. So directly acting oral anticoagulant. These are as effective as warfarin in prevention of stroke. but there is less risk of intracerebral hemorrhage. So that's a big advantage, and it doesn't need any monitoring. So before starting, we do the coagulation screen and liver function test, but after starting, it doesn't need any INR check or any further monitoring. Disadvantage is short life, so it has to be taken regularly, and its reversibility is not as easy as with warfarin. With warfarin, if there is any problem like high INR or bleeding, we can reverse it by giving vitamin K. Whereas with DOAC, we need to admit them and give them fresh frozen plasma to replace the clotting factors. So there is no direct antidote for DOACs, but it very rarely causes bleeding problem. Dose adjustment, so this is all in our British National Formulary. So depending on age and depending on renal function, kidney function, we may have to adjust the dose. So not one dose is suitable for everyone. It depends on age and renal function. So I just to put it as the adjustment, what we do according to British National Formulary. I will share these slides with you, so you don't need to read it now, but you can check or you can take a picture and keep it in your phone. If you want to start apixaban, how to adjust the dose, you can check. You can take it from here, or you can check BNF or your pharmacology book or chart. So same thing, dabigatran, you need to do some adjustment depending on age and creatinine clearance. Rivaroxaban also needs some adjustment. Edoxaban, so with your reduced weight or if the creatinine clearance is low, then you need to halve the dose. So that's about the anticoagulant. So we can use either warfarin or directly acting oral anticoagulant. Heparin we use mainly during intraoperative period, before operation, and if someone needs anticoagulation before cardioversion, then we use heparin. But in primary care, we use either DOAC or warfarin. Now, if the patient has got increased risk of bleeding or not willing to take warfarin or DOAC, then we can use antiplatelets. So we can use combined aspirin and clopidogrel, although it is not as effective as anticoagulant in preventing stroke or thromboembolism. Now, about atrial fibrillation and driving. So motorcycle and medium vehicles like kart driving is allowed unless it's causing symptom while driving. If the patient cannot stop the vehicle because of arrhythmia, or if it affects driving, then they have to stop. Whereas coach and lorry driver, they need to inform DVLA in UK. So if someone has got arrhythmia and if he drives a lorry or a bus or coach, they need to inform DVLA. But for driving normal car or motorcycle, they don't need to inform DVLA unless it causes symptoms or it impairs the ability to stop the vehicle. Flying, if it is controlled, there is no restriction to flying. If it is uncontrolled, they cannot fly. So travel insurance and all, if someone develops arrhythmia after purchasing ticket for going abroad, so they need to cancel their trip if the arrhythmia is uncontrolled. So in conclusion, atrial fibrillation is a common cardiac arrhythmia. Incidence increases with age. That's why, because of hypertension, because of atherosclerosis, because of ischemic heart disease, with age, the incidence increases. So as a primary care physician, we have got a big role in early identification of atrial fibrillation, mainly by checking the symptoms and checking the pulse. So pulse checking can detect 30% of atrial fibrillation who are asymptomatic. Atrial fibrillation increases morbidity, that is heart failure, thromboembolism, and stroke. It increases mortality. And opportunistic pulse check, as I mentioned, can detect a great number of cases. And whether to do rhythm control or rate control, it depends on several factors. It is important to reduce cardiovascular risk, i.e., dyslipidemia, hypertension, diabetes that need to be controlled, which I didn't discuss separately, but obviously any heart condition or with any heart condition, we need to control other cardiovascular risk factors like lipid level, hypertension, blood pressure, and diabetes. Rhythm or rate control depends, and the prophylaxis, thromboembolism prophylaxis is of paramount importance to prevent morbidity and mortality. Thank you. Any question, or was it too fast, or I don't know? I think I finished in 50 minutes. So did I go very fast?
No.
Hello, hi. Yes.
Yeah, not too fast. It's okay.
It's
Thank
okay.
you.
Thanks.
Yeah, there's a question in chat box.
Yeah.
Please.
Yeah.
Dr. Tin?
Yeah, I'm opening it. You can ask via chat box, okay, how frequent should we check ECG after starting anticoagulant and beta blocker? A very good question, Dr. Min. Very good question, yes. Actually, we do ECG for initial diagnosis. If diagnosis is not clear, then we do 24 hours or 7-day monitoring. But after diagnosis, there is not much need to do repeat ECG because then we go along the pulse rate. But the problem, it's a very good question. The problem with pulse checking is with atrial fibrillation, sometimes it's difficult to get the rate correct, to check the rate correctly. So for that matter, initially, after say a few weeks, you can do another ECG to see the rhythm and also to see the rate. But we don't need to do it frequently. Is that okay? Or you can do once after starting treatment, but we don't need to do it very frequently because it mainly depends on the pulse rate. And sometimes it is difficult to count the pulse in atrial fibrillation, but when the rate comes down, it's not that difficult. And also now we use the pulse oximeter, that also gives the number. So if someone's pulse is 80, it will show on the pulse oximeter. Yeah.
Thank you.
Next one, thank you. Next one, Dr. Hatun, you have written, do you need to continue anticoagulant if under good rhythm and rate control? Is there any circumstance to omit or discontinue anticoagulant? Thank you very much. That's a very good question. Once we start anticoagulation, we should continue. Even when the rate or rhythm comes back to normal, it needs to be continued. The reason is, there are two reasons. One is, even if the rate and rhythm is normal, we don't know, or no one knows, what is happening in 24 hours. So at the moment, my rate and rhythm is normal, but 11 p.m. at night, I may have a episode of arrhythmia, and that can increase the risk of thromboembolism. So if we anticoagulate, we should continue it indefinitely unless they have got any bleeding or they develop any contraindication to anticoagulation. That's a very good question. Does it answer your query? Is it clear? And this is also the reason for giving anticoagulation to paroxysmal atrial fibrillation, because we don't know what happens in this 20 or in 24 hours period or in next 7 days. We don't know when the heart will start acting funny. Yeah. So,
Dr. Ghosh, there's one question that we missed. Dr. Hainter, he asked a question. So his question was, can metoprolol extended release be used in atrial fibrillation?
sorry?
Can metoprolol extended formula be used in atrial fibrillation? This is the question from Dr. Hainter. We just missed
Extended formulation of
metoprolol.
metoprolol. Oh, right. Sorry, I missed that. Yeah, metoprolol. I think the answer is yes, but in UK we use mainly bisoprolol, carbidopa, and nebivolol. Because these three are more cardioselective. Metoprolol is also cardioselective, but personally I don't use. I use mainly bisoprolol, so I cannot tell with certainty, but I don't think there is any reason why we can't use it. I will check and I will let you know. But I think it can be used because metoprolol is also a cardioselective one. I'll check and I'll let you know.
Thank you, doctor.
Thank you. How frequent should we check? Yes, okay. Yeah. Any other question? How long anticoagulation? Do weightlifting or cardios? A very good question, Dr. Min. Thank you. Yeah. For any cardiac condition, we advise patients to do exercise according to their tolerance. So they should not do anything which makes them symptomatic, which means breathless or chest pain. So for ischemic heart disease, we always tell them not to do a strenuous exercise, which can make them feel pain in the chest or which can cause breathlessness. Same thing with atrial fibrillation. We always tell them not to do anything which can make them feel breathless. So yes, if it is controlled, they can do exercise, but strenuous exercise should be avoided.
Yes, thank you, doctor. I think there's one question I think we missed again. The question was how long anticoagulation is written with diagnosis of proximal AF. So it should be used, and that patient have no other risk factors, and age is about 50 years.
Sorry, how frequent?
Sorry, the question was how long anticoagulation in sinus written with diagnosis of proximal AF.
Paroxysmal AF, if the rhythm becomes sinus rhythm.
Sinus rhythm, yes, doctor.
Whether to give anticoagulation.
Yeah, for like how long, the duration.
Yeah, the answer is yes, they should have anticoagulation and it should be continued indefinitely unless there is any increased bleeding risk or any contraindication develops during treatment. Because the same thing with the paroxysmal atrial fibrillation is even risky because you don't know when they will go into another episode of atrial fibrillation.
Yes, thank you, Dr. Ghosh.
If you can successfully cardiovert someone, then you can stop anticoagulation. But if you have not been able to successfully cardiovert, then anticoagulation should be continued lifelong.
Yes, thank you. One more question is from Dr. Joe Pio. Is it still possible to use metoprolol or bisoprolol who has asthma history, although it is cardioselective?
Yes, a very good question. Bisoprolol, nebivolol, and bisoprolol, nebivolol, and carbidopa, these are cardioselective, can be used in asthma, but if the asthma is brittle or severe, then you can use diltiazem or verapamil instead of beta blocker. But as you said, it's cardioselective, so it can be used. But obviously, if someone has got very poorly controlled asthma, or if someone developed severe asthma after giving beta blocker, then it is better to avoid and give metoprolol or diltiazem or verapamil.
Thank you.
Thank you. So, I mean, for primary care, it's most important is to diagnose, and because we see lots of patients above 80, 85, for them, we need to use some clinical judgment, whether they should be sent for rhythm control or shall we just control their rate, prevent thromboembolism, and prevent stroke and sudden cardiac death. So that's what in primary care we need to decide. And most important is if someone is hemodynamically not stable, tachycardia of 150 with symptoms, they should be sent straight to the hospital.
So there's 3 new questions from Dr. Han Winton. The first question is, do we need to undertake coagulation tests before prescribing noble oral anticoagulants?
Yeah, Dr. Toon, this is a very good question, and we face this frequently in our clinical practice. Yes, we do a liver function test, kidney function test, and coagulation screen before starting anticoagulant because the reason is simple. If someone is coming with arrhythmia, my first aim is to reduce the rate and control the symptom. Anticoagulation I'm giving as a lifelong treatment to prevent complications. So if I don't give anticoagulant on the first day and give it in a week time, yes, within a week also someone can develop thromboembolism, but possibly we can wait for a few days to do the blood test because we need to know the renal function. That is important. And the coagulation screen we should do because once you start the DOAC, your coagulation screen checking will be very difficult to interpret. So we try to do a baseline one before starting anticoagulant. And usually here we get the result within 24 hours. So if I request someone to have a coagulation screen today, by day after tomorrow, I'll get the result. So a couple of days later, if I start, that will not make a major difference. Second question is, can you start?
Yes, second question is, what can we do if the
test results are abnormal? Yeah, if the test results are abnormal, obviously, if their coagulation screen is abnormal, which could be due to multiple factors. One is it could be due to liver function test abnormality. It could be due to thrombophilia like factor V Leiden or protein C, protein S, or antithrombin 3 deficiency. Obviously, those are the reasons for having abnormal coagulation profile in a patient without any known history of any coagulation disorder. So for them, yes, we refer them to the hematologist for opinion. Safe practice is you can give low molecular weight heparin. So you can give enoxaparin 40 units daily and refer to the hematologist and get their opinion. They might do thrombophilia screen. They will do thrombophilia screen, and then they will advise accordingly. So I will not start DOAC if the coagulation profile is abnormal. I will rather give heparin, low molecular weight heparin, enoxaparin, or Clexane, and refer to the hematologist. Very good question. Third one, sometimes taking antiplatelet. Yeah, this is a very good question. The patient is already on antiplatelet medication, sometimes taking double antiplatelet. Can you start NOAC in such patients in parallel to antiplatelet? The answer is yes, because quite often people are on antiplatelet for ischemic heart disease or after putting stent. For them, we can use DOAC in addition to antiplatelet because the two are working in two different ways. One is thinning the blood, preventing clot formation, whereas antiplatelet is making the platelets less sticky. That way, it prevents the worsening of the coronary artery spasm. So that's why, yes, cardiologists, they use antiplatelet and DOAC together. But if in doubt, we can ask for advice and guidance from our cardiologist colleague. But we have got quite a few patients who are on antiplatelet and on DOAC for atrial fibrillation. But usually we take opinion from the cardiologist. Last, the duration of treatment with NOAC in paroxysmal AF is lifelong unless there is contraindication or any complication develops. So basically, yeah, the questions are really good questions and very interesting. So basically, when it gets a bit complicated, like someone is on antiplatelet, whether to give DOAC or not, or someone has got abnormal coagulation profile, whether to give DOAC or not. In that scenario, here now, previously we used to refer to hematologist or cardiologist, but now in UK, we have got an advice and guidance service. So we write the history, we write the clinical question and send it to, email it to our cardiology colleague or hematology colleague. And within 1-2 days, we get the reply and then we inform patient accordingly. So sometimes we need a shared management. We need to discuss with the specialist colleagues. Obviously, we can't do everything on our own, particularly in primary care where we cannot monitor patients on a day-to-day basis. That frequently. So yes, we need to take the opinion from the specialist. Yeah. Any other question or any comment?
Dr. Ghosh, there's one more question. So from
Sure.
Vic, how can we manage atrial fibrillation in pre-excitation
Wolff-Parkinson-White in primary care as beta blocker and CCB are contrary? Yeah, good question. Wolff-Parkinson-White. I'm not sure, but obviously same thing. If in doubt, best thing is to refer this type of patient. These are the complicated patients, isn't it? Atrial fibrillation in pre-excitation, Wolff-Parkinson-White. Refer to the cardiologist. I'm not sure about how to manage in primary care. Probably advice and guidance or refer to the cardiologist. So obviously, if someone is symptomatic, if we are not sure how to manage, we can always refer them to the hospital on the same day. But I need to check the metoprolol as well, and then I'll let you know. Very good question. Wolff-Parkinson-White also I'll check, and if I find the answer, I will let you know. I'll let Dr. Mimitai so that she can communicate with you. Beta blocker, CCB, and Wolff-Parkinson-White. Yeah, thank you. That's a very good question. Any other question or comment? So what you do in Myanmar, if you diagnose atrial fibrillation on basis of pulse checking, do you arrange for ECG? Because I know in some of your clinics you have got ECG, so do you do ECG?
We refer for ECG and 24 hours Holter monitoring.
Yeah. And if it comes as atrial fibrillation, do you start treatment or do you refer to cardiologist?
No, refer to cardiologist.
Yeah, we also used to do that, but because now, we are more equipped in the primary care. We have got ECG machines and all. So especially in elderly patients, we treat in primary care. In young people, we refer them as soon as possible because they may benefit from cardioversion. That's why we refer them to hospital. And those with complications or hemodynamic instability, very rapid pulse, we refer them to the hospital. Yeah, but elderly patients without any other complications, we usually manage them in primary care. Another reason for doing an echocardiogram, we can do it from primary care, not in our practice, but they go to the community center and they get an echocardiogram. Another reason for doing echocardiogram is if they have got valvular abnormality, any valve abnormality, then drugs are not suitable. They possibly will need warfarin. So that's why we make sure that there is no valvular abnormality in atrial fibrillation. That's why we routinely do echocardiogram. So we do bloods, ECG, chest X-ray, and echocardiogram.
Thank you, Dr. Subir. Very interesting.
Thank you
Yeah.
very much. Thank you. No, it's really, really nice, and I really enjoyed the interaction, and I really like the questions. They're very, very, very interesting and thought-provoking. Thank you. And tomorrow is Thadingayat, is that right?
Yeah, the Rinchot, full moon day of the Rinchot.
Yes. So I wish you and family a very happy Thadingayat.
Yeah, thank you very much. You too.
You're welcome. Thank you. So what I will do, I will send this presentation to you, Dr. Memitai, and then you can send it to the participants.
Okay. Thank you.
Okay.
ဆရာတို့မေးစရာများရှိသေးလားဟိုမိုက်ဖွင့်ပြီးလဲလူကိုယ်တိုင်လည်းမေးလို့ရပါတယ်နော်ဗမာလိုဖြစ်ဖြစ်အင်္ဂလိပ်လိုဖြစ်ဖြစ်မေးစရာလေးများရှိရင်ပြောလို့ရပါတယ်မေးစရာလေးများမရှိတော့ရင်တော့အစီအစဉ်ကိုသိမ်းမှဖြစ်ပါတယ်ဆရာတို့မေးစရာလေးများရှိပါသေးလားမရှိရင်သိရင်ဟိုပါလေ Thank you remarks နဲ့ conclude လုပ်လိုက်ပါ
ဟုတ်
Thank you, Dr. Thin Tuhetai. Thank you very much. Thank you, Memitai.
Thank you, Dr. Subir, for the presentation. Okay. အခုလိုမျိုး atrial fibrillation အကြောင်းကိုပြည့်ပြည့်စုံစုံပြောကြားပေးသွားပါတော့ဆရာကိုလည်းကျေးဇူးတင်ပါတယ်မအားလက်တဲ့ကြားကမြန်မာပြည်အနေနဲ့ရရက်ကတက်ရောက်အားပေးကြတော့မိကုံများကိုမြင်မြင်ပေးကြတော့ဆရာဆရာမတို့အားလုံးကိုလည်းအထူးပင်ကျေးဇူးတင်ရှိကြောင်းပြောကြားလိုပါတယ်ရှင်အားလုံးပဲမင်္ဂလာညချမ်းလေးပါရှင် Thank you so much